Everyone. I'm Dr. Williams, Chair of Medicine, and it is my privilege to introduce our speakers, introducer, Dr. Mohammed Saad, our Chief of Pulmonary Medicine. He is a specialist in sleep medicine, and he has been running a spectacular division. And he has a very, very special guest, whom I've learned a lot about since he was chairman of medicine here back until about 5-6 years ago. And that's Jesse Roman. So we're going to hear today about lung disease and the aging, and the proper introduction will be Dr. Mohammed Saad. Thank you so much, Dr. Saad.
Thank you, Dr. Williams. Good morning, everyone. It is my honor and privilege to introduce Dr. Jesse Roman. Dr. Roman is Ludwig Kind Professor of Medicine at Thomas Jefferson, and he's currently holding a position of CEO and Director of Leonard Korman Respiratory Institute of Jefferson Health and National Jewish. He's also Editor-in-Chief of the Journal of Medical Science. And just a brief history about Dr. Roman journey as a scholar. He completed his medical school and residency in Puerto Rico and fellowship at Washington University. Stayed on as postdoctoral research there for 2 years before starting his academic career at Emory, and moved up until he became division chief. And we were lucky to have him joining us as a chairman of medicine in 2009. And to his credit, he developed all the subspecialty in our pulmonary division, especially the ILD, and being a site of the Pulmonary Fibrosis Foundation. It's all to his credit. A true scholar and a scientist, and nationally recognized. As I said, it's been a joy to work with him and learn from him, and also listen to him. He's a fantastic and eloquent speaker, and very knowledgeable about the topic of ILD and numerous publications. And I'm sure that you guys are going to enjoy his talk today about aging lung. So thank you, Dr. Roman, for taking time out of your busy schedule. And go ahead.
Great. Well, thank you very much, Mohammed. Thank you for those kind words. It's truly a pleasure to be back. As you may or may not know, I was in Louisville just yesterday visiting my daughter. It was just bad timing because I have a full clinic today that I could not change, but I would love to be there. I've been out of Louisville for about 6.5 years now, and I miss it. I miss the city. I miss the food. I miss baseball, but mostly I miss the people. And I know that Dr. Williams, if he's experiencing what I experienced, I'm sure he's seeing a family coming together to take best care of patients, and training and discovery and so forth, and all the traditions that academic medicine has to offer. So thank you for having me. It's a pleasure to be back. So why don't we get started? Let me see. I think that I would know how to do. There you go. So here are my disclosures. I engage in clinical trials. I'm involved with a number of associations as council or board member. I do some basic research funded by the NIH, but I don't engage in speaker bureaus except for the Mohammed Saad LLC Speakers Bureaus organization. So when he calls, I answer. Now, you might recall that in my day, we used to start grand rounds with what happened on this day. And the intention was to get back to people or events that actually inform what we do today. So I looked back a little bit and I found Nicholas Culpeper, who was born on this very day in 1616. He was an English pharmacist and physician. He published a book on complete herbal, okay? And he wrote that any man using his herbal could preserve his body in health or cure himself, which to me is about preserving youth, preserving health, delaying or preventing aging. So that's an interesting one for our conference today. And then this gentleman, Albrecht von Haller, who was born on 1708, who was a Swiss biologist, considered the father of experimental physiology. He was the first to recognize the autonomous function and the beating of the heart, but he also the first to recognize the mechanism of respiration. So these two guys, 300+ years ago, sort of laid the foundation for what we're going to talk about today, aging and lung. Now, it's always nice to start ground rounds with a case. So I'm going to give you a case. This is a 67-year-old Hispanic female who came to us with progressive shortness of breath, very typical for what I see in my clinics. Was limited, mainly going upstairs, although she could do well at level. She had cough. She had no obvious environmental exposures. She had been a smoker, quite a heavy smoker. She was thin. She had clubbing in her fingers. She had crackles in the lung bases. And as you can see in the CT scan from top to bottom, first of all, you start seeing some holes. Do you see my arrow, Jason? Do they see my arrow? I don't know if they see my arrow, but you can see on the top here, on the second.
I did for just a second, but now, yeah, I don't now.
How about now?
Yes, there you go.
Okay, so you see these holes there, and that's destruction of lung tissue caused by emphysema. And as you go down, you start seeing some white areas and some thickening of the interstitium. And basically, this person also has fibrosis. It turns out this patient had emphysema and idiopathic pulmonary fibrosis. And we'll get back to this because it highlights what's important about the aging lung and how susceptible the aging lung is to tissue disrepair. Now, what are objectives today? Well, we're going to discuss aging, what happens to the structure of the lung, what are the implications of having such alterations in lung health and disease, and what are the contributing factors, and what can we do about it, if possible, at this stage. Now, many of you will say, I see Lori Earnshaw there, she's going to say, well, we know what you're going to say, Jesse. Aging is bad for you. There's not much we can do, but I ascribe to Chevalier's saying old age isn't so bad when you consider the alternative. So keep that in mind as we go along. Now, there are a couple of things that I want to mention before I continue. And there's two concepts that I want you to keep in mind as I give my presentation. Number one is that when you discuss the concept of aging, it's too broad. You would think like, how will we ever conquer aging? It's too complex, too broad, too difficult. And what you should know is the scientists have been dissecting, compartmentalizing processes that are related to aging, from senescence to proteostasis that I'll talk about. And in doing so, they can focus on a few genes, on a few products, on a few signaling mechanisms, and try to intervene there. And in doing that, multiple groups around the country and around the world are tackling aging, but by focusing on very specific areas that allows us to put our heads around specific processes. And I think that will be a good approach to dissecting this overall complex problem. The second issue I want to mention is that even though I'm going to discuss the lung today, I think everything that I'm going to say sort of relates to your very own favorite organ. So even though this is a pulmonary lecture, you're going to see a lot of things here that relate to the heart, to the liver, to the brain, to the skin, and to your favorite system. So this is a slide you all have seen or seen something like this, showing that the U.S. population is aging. This is from the Petershill Foundation a couple of years back. And you can see that in 1975, the U.S. had about 10% of the population were 65 years or older. Then later 12, we're now around 16. They predicted at that time we will be at 18 by next year, that we will be at 21% of the population will be 65 years or older. I will be included in that statistic. And they predict that by 2050, 21% will be there. But look at Florida. Florida is already there at 21%. Now, the next image is a little more difficult for you to see, but let me just make it very clear to see where the United States is. These are the countries that are older. In other words, they have a older population. Notice that Japan is way up there. Greece, Italy, almost 29% of the population, 65 years of older. Think about the implications for patients, for the healthcare system, and so forth. And look at the younger countries, New Zealand, Russia, Cuba, Taiwan. United States is right here, okay, at around 16.8% and climbing. Tremendous implications to what we do at the clinic and what we do in the hospital. Now, I want to go back to our case. Remember, the patient had emphysema, a component of the larger entity called chronic obstructive pulmonary disease, or COPD, and IPF. These conditions are conditions of aging. If you have a patient that comes to you at age 25, 30, 40, who has significant emphysema or pulmonary fibrosis, you got to look deeper because it's unlikely. This occurs after you age. And in this country, the majority of emphysema is related to tobacco exposure, unless you have a genetic condition. And it takes years for you to smoke and be exposed to that to develop this process, both females and males. And the same thing happens in these 6 studies published in the area of IPF, that as you age, you see that. And again, if a patient comes to my clinic younger than 50, 55 years of age with significant lung impairment and destruction due to fibrosis or emphysema, it's not any of these diseases, or I'm missing a genetic predisposition or some other exposure that we need to figure out. Again, diseases of aging. So as a pulmonologist, I spend my days taking care of diseases of aging. Now, this is true for other systems. Now, if you look at arthritis, heart disease, cancer, diabetes, all of these go up as you increase in age. Perhaps asthma is the only one that stays, probably because the airways begin to stop being hyperreactive and become less responsive bronchodilators, and now you have remodeling, you call it COPD. That may be the reason we see the asthma prevalence not changing with age. But in general, we all see increase in these general internal medicine conditions. I want to spend a little time on this slide, which you can't see very well over there, but I'm gonna name each and one of these issues, because I told you that what scientists are doing is, instead of looking at the process of aging, they're dissecting its components. So up here, you see genomic instability, DNA not being able to repair itself as it should. Telomere attrition. Telomere are at the ends of genes, and they prevent your gene from shortening, which happens during aging and disease and oxidative stress. And we lose that. And telomere attrition has been found important in fibrotic lung diseases, for example, and others. Epigenetic alterations, not in the DNA sequence, but in how methylation and all the epigenetic changes that occur in the gene are all altered during aging. Loss of proteostasis. We can't get rid of bad proteins. Autophagy is disabled. We can't get rid of bad things. The cell accumulates these toxins that we produce by abnormal metabolism, and the cell becomes dysfunctional. We have deregulation in our nutrient sensing. We have mitochondrial dysfunction, which already creates problems with energy production and oxidative stress. Cellular senescence, which I'm going to end with the slides about cellular senescence, very different. Senescence from aging. Aging and senescence are not the same thing. I am aging. I am not senescent. Stem cell exhaustion. We have stem cells almost in every organ that can help you regenerate after injury, but we lose that capability as we age. Altered intercellular communication. Chronic inflammation. We all get more inflamed. Dysbiosis, our gut microbiota, our lung microbiota, our oral microbiota changes as we age. So no wonder, as we age, we are more predisposed to chronic conditions, because all of these processes have been found to be abnormal. Now, we're not going to be able to discuss all of these. I'm just going to focus on a couple of pieces of this. Now, this is also a complex slide, but I wanted to bring you that so you can see the review article. If you want to look at it, Mohammed, for you and your student, it may be interesting. On the left side, you see the young lung and what the authors depict is happening from the upper airway to the middle bronchi and then to the terminal airways and alveoli, and you see what happens in the old. And what they're describing here is very simple. Basal cell, ciliary beat, mucociliary clearance, all of those are going down as you age. And you have alterations in the extracellular matrix. And then you have destruction of the alveolar septi. And you have decreased elasticity. People talk about the emphysema of aging in large air spaces, tremendous alterations in the connective tissue of the lung as you age, and the implications that that has on cell behavior. That's what's happening in your lung. Think about what's happening in the heart and the liver and all these things while you're listening to this. I'm going to focus a lot on the matrix because, as you know, that's my interest, but I'm going to give you some clinical pointers so that it becomes relevant. Again, go back to my patient. Patient has emphysema, which is destruction of the alveolar septi. Pulmonary fibrosis, which is destruction of the lung architecture from excessive deposition of collagen. These are diseases of the connective tissue. These are diseases of the connective tissue that occur by aging, and aging affects the lung matrix. And so I like to talk about this concept of tissue remodeling, because when people talk about destruction, they think about emphysema and fibrosis, which are terminal entities. But the process of tissue remodeling means that your matrix is continuously being altered, and the cells are sitting on that matrix and they're behaving differently. Why? Well, in part because they don't live in vacuum. But notice how this is important for every single disease that I take care of. There is no disease that Jesse Roman takes care of that's not associated with alterations and remodeling. Destruction of alveolar septa, thickening of the airway in asthma, destruction of the tissue and cavity formation in tuberculosis, fibrosis, we'll talk about that. Even cancer, the interaction of cancer and the matrix around, people talk about cancer stroma or cancer fibrosis, and even vascular disorders where you have alterations in the vascular structure from hypertrophy of some muscle cells and excessive matrix deposition. All of these are alterations of matrix, and the matrix is not the end stage of the disease. It is part of the disease. And the reason is, as I mentioned, because cells are not floating. They're not floating in the air. They're actually encased, submerged, immersed in a matrix. So you can think of, if you're seeing Jesse Roman from home, from your favorite room with your favorite cup of coffee, versus sitting in a chair in the conference room with no coffee and the walls are painted in black. I don't know what they're painted out today. You are behaving differently. You're getting this interaction in a different way. Well, the cells are able to do the same if they're sitting in a very abnormal matrix. And the reason is that just like you and me that have eyes and fingers and ears and touch, cells are binding to certain receptors. A cell knows when it's sitting on collagen. A cell knows when it's sitting on fibronectin. A cell knows when there's a lot of proteoglycans. So a cell alters its behavior when it's doing that. So if you can think about an aging lung having an altered matrix, you're also acknowledging that that aging lung has an abnormal cell behavior that may have implications for why, as we age, we have more likely susceptibility to injury. Now, this is an integrin. You're gonna say, well, Jesse, that's too complicated. No, it's very simple. Here's a cell. And a cell on the apical surface is binding to a lot of matrices, fibronectin, collagens, proteoglycans, and the integrins bind to each other. And they signal, they activate kinases, pH changes, calcium, the same thing for the base membrane. See how complicated it is? Cells have the ability to detect their surrounding. And if I alter it because I'm getting older, the cells behave accordingly. That's an important concept. So what have we learned? We've learned that lung disease is associated with tissue remodeling. We've learned the cells encased in abnormal matrix behave differently. And what are the next questions? Well, first of all, Jesse, is that really true? Is there evidence that that's the case? Are you fooling me just because you're not here physically that we can go up on the stage and smack you? What's going on? And how does this relate to aging? Well, let me talk about that. So couple of slides just to make it simple for you. If you take a lung out, you can actually put it on a plate and infuse it with fluid and decellularize it. So in other words, you're left with only the matrix. You can take all the cells and DNA out. And so what you see on the left-hand side is two lungs, one taken from a fibrotic patient, from a patient with IPF, who is going to be transplanted, a normal lung, okay? And as you can see, there's a lot of damage here, and there's a nice white tissue here. When they section that tissue with different matrix components, you can see that the original architecture of the lung remains. Why? Because that matrix sort of sustains that architecture. And so they said, what if we throw cells on top? What if we throw normal cells on top of an abnormal lung? What would they do? Well, actually, if you look at protein by Western blotting, you can see that this protein starts going up in a cell that is sitting in an abnormal lung, okay? This is alpha-synuclein. This is a marker of myofibroblasts, and myofibroblasts proliferate and become problematic in the setting of profibrotic changes. So this is the first evidence that I'm going to tell you that an aging lung has somewhat of a profibrotic phenotype. So when we get injured, our first reaction is to respond by fibrosing. That's an important concept. Okay. The other concept is that the matrix is important, and you can't just take a mouse and eradicate a matrix because they're important for embryogenesis and the animal would not develop. But you can take specific genes. This is an animal that is deficient in a fibronectin glycoprotein splicing variant. What's important here is that when you injure that animal with a bleomycin, which, as you know, is an anti-cancer agent that can cause fibrosis, these animals that don't have this gene of matrix are protective. See how there's a lot of connective tissue and inflammation here? There's more preserved lung architecture, which means that the matrix you have in your lung makes the difference. It makes a difference. What have we learned? Lung disease is associated with tissue remodeling. Cells encased in that abnormal matrix behave differently. Normal cells on top of that abnormal matrix respond differently. And matrices can affect a response in a profibrotic way because they react to profibrotic genes. Now, what does that have to do with aging? Now we're getting to the crux of the matter. Now, many of you may have seen me use this slide in the past. It's Sanjay Gupta. I lived in Atlanta for many, many years. My wife was in love with Sanjay Gupta. I bring this up, but this is how Sanjay, AI, sees Sanjay moving at age 100. So let's talk a little bit about aging. So the aging lung, I'm not going to tell you anything you don't know yet because I already talked to you about the hallmarks of aging, but in the lung itself, it's been shown that there's increased oxidative stress, there's increased inflammation, there's abnormal mitochondrial function, there's abnormal immune responses, and the ability to regenerate because of their stem cell potential is decreased. But when you look at the matrix, it's also terribly affected. What's called the emphysema of aging. Elastin is down, collagen is up. We've known this for decades. Look at the dates of these papers. We've known this for several decades, that the matrices are altered, that the matrix destructive enzymes are upregulated, that the matrix is altered by protein modification. We're walking around, not you, the young people like me and older are walking around with an altered matrix. And we try to model that in a mouse because we said, if we're going to study this, we're going to have to do it in mouse. So look at a young mouse and an old mouse. If you are a mouse doctor, you know that a young mouse is about 3 or 4 months old, and an old mouse is about 18 to 20 more months old, okay? If you stain with a stain that detects collagen, this is trichrome stain, you can see that there's more blue on the old side. That means there's more collagen. The architecture looks okay. That lung is normal. Older people are doing fine. They're going to the movies and going to restaurants and doing their thing, but they have more collagen. They have more destructive enzymes. This is a gel coated with the nature collagen. And when you degrade it, it becomes white, where there's more degradation activity in a normal aging lung of a mouse, but in a human as well. And if you look at genes that are related to fibrosis and disrepair, they're all upregulated in a normal aging mouse. In a normal aging mouse. But they're walking around like a time bomb. And so we've heard about that. Let's summarize. What are the implications, Jesse? What are the implications of this? Well, the first thing is our mechanics are abnormal. The pulmonary group knows, or they should know, that if I do pulmonary function tests on a yearly basis on my patients, my FE1, the fractional excretion of volume per second, is going to go down after age 20, 25. We lose about 25 cc's per year. And that's important for Mohammed and his group, is because I can follow that. So if you come back in 5 years and I've lost about 100 cc's, that's understandable. But if you lost 100 cc's in 6 months, I got to dig deeper and find out what's going on. But basically what's saying is that structure of the lung has functional implications. And if we look at elasticity, the same. This is pressure at the bottom. and volume, and I need a certain amount of pressure to expand the lung. But if I have less elasticity, that curve shifts to the left, to the white curve. So I need less pressure to expand the lung. That's emphysema. That's emphysema. So the aging lung has an abnormal structure and therefore has an abnormal function. Normal for the age, but is different than a young individual. And that indicates susceptibility to injury. This is a mouse lung treated with bleomycin. And as you can see, an old animal, when you take the lung, there's more injury here. I don't even have to tell you what this is. This is bleomycin. But go to your ICUs. Go to the floors at your hospital. Go to Jewish and University Hospital. Almost everybody that we treat as internists are over 50, 55 years of age with these conditions. Not everybody, but many of them. So I don't need to hamper on this point other than the aging lung is susceptible to injury. It's also susceptible to lung metastasis. Here's an animal that we gave him bleomycin. They lose a little weight after giving bleomycin because they're sick and they're not eating so well. But you can take the lungs out after you inject a tumor into the subcutaneous area. And after a few days or weeks, you find that there's tumors in the lungs. You can count those tumors. Okay. Now look at the bottom slide here. If you take a young animal and you treat them with just buffer or bleomycin to injure them, and then you inject tumors, they will not have lung metastasis. But if you take an age mouse, they will have lung metastasis. And in fact, it takes about 7 to 8 months in our hands to be able to develop lung metastasis. And if you injure the lung, it's even more. So what does that tell you? Is that you have a lung that is susceptible to reaching, accepting, and allowing for the growth of tumors as they grow, as they move into, think of melanoma, for example, or colon cancer, or renal cell carcinoma, how easy it is to grow the lung in an aging individual. And if I have a lung that is abnormal because it was injured, it has a little fibrosis or emphysema, it's even more likely to get there. I will not show you the data, but if I use that animal that is deficient in fibronectin, that animal actually, that increase goes down, suggesting that we can control this by controlling the matrix. So again, susceptible to injury, mechanics are abnormal, susceptible to metastasis. What have we learned? Lung disease, tissue remodeling, cells behave differently. The normal aging lung is more susceptible to injury. The aging lung is profibrotic in its phenotype. That's how it responds to injury and is susceptible to lung metastasis. We see that in our patients all the time. So can environmental factors affect this, Dr. Roman? Can that be worse? Even if you're a young individual and you smoke, for example, could I have an age lung at age 35? Absolutely. We think that is the case. So let's talk about what are the contributing factors in future interventions. So you may have seen this in the past. This is now old data, but we have more data since then. But I think this is the most descriptive. These are lungs that were fed nicotine in the water. I don't smoke, Dr. Roman. I only vape. And the vaping that I do has 4 milligrams of nicotine, which is 4 times what a regular cigarette does. And that's okay because I'm not smoking. Well, you are vaping and you have nicotine. This animal was fed nicotine in the water. And if I stain for matrix, in this case, fibronectin, you can see all that dark tissue in the vessels and the septine and the bronchial structures, how it's more darker because the matrix is altered. Nicotine is affecting the matrix of the lung, and that lung looks like an aging lung and is more likely susceptible to injury and metastasis. So you look at chronic alcohol abuse, you look at post-lung transplantation, you look at people exposed to air pollution. All of those things will begin to alter your microenvironment where cells live and therefore cell behavior. And we live and we work under the hypothesis that a young matrix, if you insult it, it has all the capacity to repair itself, adaptive repair. If you have too much injury, a train runs over you 3 times, that may be too much. There's just no way to get out of that. That will be maladaptive repair. I don't have any of the original structure and basement membranes to repair the home. I don't know what's left. But think about an aging lung that may have an aging or senescence matrix. And that insult might be as similar to this other insult, yet I still cannot repair appropriately because I start off with an aging matrix. That's the hypothesis that we're working on, and will take us another few years to document formally and to look for interventions. So we've learned all of this, and we've added that environmental exposures. Think about diets. Think about prematurity. Think about being a child in a house where the parents, both of them, smoke a pack a day. All of that can promote the remodeling of the lung. The lung looks okay on CT scan. In fact, you may cut it, and the pathology will say the lung looks normal, but it's not until you look at biochemically and other molecular structures and you find that lung is very, very abnormal. So what triggers this, Dr. Roman? How do you go after this? Now, I'm going to talk a little bit of oxidative stress here, okay? And everybody is aware of oxidative stress and can hit the cells and cause oxygen radicals, lipid peroxidation, DNA damage, protein denaturation. But I want to talk about a different kind of oxidative stress, and that is redox stress. And I'll show you why that's related to aging in a minute. But first of all, you all know about oxidative stress because you have less glutathione. If you drink a lot, by the way, you have 100 times less glutathione protection in your lung, even though you may be okay. You produce oxygen radicals. Your NADPH oxidase is abnormal. I'm talking about redox state. Everybody has glutathione disulfide in their body. They have cysteine and oxidized cysteine. Those ratios, cells are able to detect that. Cells are able. So Jason Puckett probably has, if I take his plasma and I put his plasma into an HPLC machine, I can quantify cysteine and cysteine and come up with a number. And Jason will be at minus 80 millivolts. And Jason will go back to his family and say, I am normal. Okay? But what happened if Jason was oxidized? Well, Dean Jones taught us how to do that. But one of the things we did with Dean Jones is to show that if you culture cells, lung fibroblasts, in the presence of oxidative material, those cells proliferate more and those cells make more matrix. So if you're walking around with an oxidized redox state, your lung has more proliferation of fibroblasts and you're producing more aberrant matrix, no matter what age you are. And one of the things that Dean did some years back, almost 20 years or so more, and Dean Jones is an expert in this area, he's really driving this field. He took people who were from 20 to 90 years of age. He's now done hundreds and hundreds of these people. This is an early paper. And we looked at the ratio of glutathione disulfide, or cysteine. I told you that you had millivolts. He showed that they were getting more oxidized. If you go from here to here, you can see that it's becoming more oxidized, okay? And so as we age, our redox state becomes more oxidized. That is normal during aging. But you can start thinking about, wait a minute, if that induces fibroblast proliferation, if that induces matrix production, that may be one of the reasons why my aging organs are altered. And he's shown, and he's published, that these millivolts, minus 80 if it's cysteine, or minus 140 if it's glutathione disulfide, the number is not important, but what's important is you become oxidized if you don't eat a good diet, if you're aging, if you drink too much of alcohol, if you have diabetes, if you're a chronic smoker, if you have coronary and cardiac disease, if you have chemotherapy or BMT transplantation, atrial fibrillation, lung transplantation, everything is starting to slowly move that needle towards oxidation, no matter what age you have. And now you're walking around with these disorders, but an aged lung. That's the point I want to make to you, with all the implications of mechanics, susceptibility to injury. We looked at patients with IPF and we saw that all of them, their plasma was oxidized. Here's the normal, minus 80 millivolts. They were none of them reached that level. They were walking around oxidized. This is another way to depict this. Notice that they're going from this level, minus 80 or so, to this level, more oxidized. Okay. And So why does this happen, Dr. Roman? I'm going to summarize about a decade of work here, but I now need to bring attention to one. I don't know if he's with us today. Bert Watson may be here. Dr. Watson, are you there? I'm looking at the names and I can't find him, but if you are, just say hello to the gang. Dr. Watson is in your group. And Dr. Watson and Dr. Sen, one of his postdocs, demonstrated that the problem we have in lung fibroblasts that are aging is the absence or decreased expression of this little molecule. It's a co-transporter. It brings glutamate out. It brings cysteine in. The cysteine becomes cysteine. And now you can make both glutathione. So you start seeing the relationship. And what he found was that when you look at the fibroblasts of an aging animal, they hardly have any of this transporter. But a young animal has lots of it. And he can manipulate the expression of that transporter, and that has implications. Let me show you that. This may look like a very difficult slide, but it's not, okay? So here is this transporter, SLC7-alpha-11. The name is not important. Look at the old fibroblasts, how little of this transporter they have. Here, a young fibroblast, a lot. And when you look at a number of profibrotic genes, all of them are up. All of them are up. All of these genes are up. What happens if I increase the expression of this single gene? Maybe they'll go down. Well, in fact, they do. If I transfect these cells with more of this co-transporter, now you can see they're more expressing. Look at all of these profibrotic genes have gone down. And in fact, senescence genes are also down. One single molecule, one single transporter, controlling redox state in your body, in this case, the cells. And if I can manipulate that, I can turn off the bad genes and perhaps turn on the good genes. That's I'm exaggerating a little bit here, but that's what this data suggests, that I can potentially manipulate this, Dr. Roman. Aging and control of aging and preservation of health, the preservation of youth is not too far away if I tackle each and every one of these little processes one by one until I have the right cocktail with 27 agents that preserve your lung. That's the concept. That's the concept. So here's a summary of what I've told you. We have an aging lung that has redox stress, that it has a profibrotic phenotype, but that's still okay. I'm walking around, I'm doing well. But now that creates some remodeling. And if I have an insult, a bus runs over me. I have COVID. That's why you may see fibrosis after COVID. I may have ARDS in the ICU. Whatever it is, I may end up with a fibrotic phenotype. Start thinking about the things you could do to prevent this. Certain antioxidants, SLC inducers, by the way, sulfonamide and sulforaphane are available. People can use some of these in the clinic for other conditions. They affect the expression of the co-transporter. They're available. How about integrin blockers? We're now testing an integrin blocker in the setting of idiopathic pulmonary fibrosis. These blockers are available out there and they're safe for human use. How about the things that may create an aging lung, Dr. Roman? Tobacco, chronic alcohol, infection, pollution, bad diets. How do I attack those? Cessation, vaccines, healthy diet. You know all of these. The same thing I tell people, it's easier to take a pill than to change behavior. I get it. But think about a way to preserving aging. I just saw in Louisville, my granddaughter who's 1 year old. And my whole goal these days is how do I preserve that lung? So I can see my daughter going to high school and then to college and getting married and taking me around as an old man, that kind of thing. I'm almost done. I have two more slides, and I think you'll find this interesting. So I'm going to bring you back to the slide of the hallmarks of aging. And I want to point you to this area here of senescence. We said how the scientists are dissecting components, and this concept of senescence is an important one. And I told you that aging and senescence were not the same. If you get an injured cell or for some abnormal genetic structure, your genes are altered, that cell becomes abnormal and could take three options. One, it can become a tumor cell. Number two, it can kill itself for the sake of the others. Okay, Jason will say, like Spock, the benefit of the one is more important than the benefit of the all. Okay, so it may kill itself, or it may not be able to do either, and it becomes senescence, dysfunctional, producing inflammatory cytokines, producing a whole bunch of agents that are affecting other cells around it that promote an aging pro-inflammatory, pro-fibrotic state. Those senescent cells are now being tackled because they express things on the surface that allow us to identify senescent cells without another cell. And these are all the areas that people are looking at. How do you detect senescence? These are senolytic agents. I put some examples here. But there are, if you look at clinicaltrials.gov, you will find over 10 trials that are working in chronic diseases from Alzheimer's to post-MI to lung fibrosis and diabetes and so forth that are using senolytic agents, agents that are able to identify senescent cells among the group and pull that out and kill it so that I cannot sustain, perpetuate, maintain that injury process. This is not too far away. This is not too far away. So let me finish to see if there's some time for conversation. What have we learned? Lung disease is associated with tissue remodeling. By the end of this lecture, you've heard this 20 times. Cells encased in that abnormal matrix behave differently. The aging lung has a different matrix, is an aging matrix, is a remodel matrix, and they behave differently. And that's why the aging lung is more susceptible to injury. That's why the aging lung has a profibrotic phenotype and responds through disrepair, profibrosis. The aging lung is susceptible to lung metastasis. There are environmental factors, or factors outside of the host that can induce this. Think diet and smoking and alcohol and other pollution. And that agents are being developed to target these pro-agents pathways. And I think within a decade, we will have one or two agents that may have an impact, but studying aging is difficult. Aging requires years of evaluation of an individual. Think about the cost of a clinical trial. I do clinical trials all the time here. It takes 40 million to do a 1-year trial. Imagine a 10-year trial to look at the process of aging. That's important, but we can get there. And I still ascribe to Chevalier's statement of old age isn't bad when you consider the alternative. So let me stop here and see if there's any comments.
Thank you, Jesse. It was a wonderful talk. And I have one question, but I want to see if any of
Before
the
you start, should I
audience...
stop sharing, or what should I do?
I can tell. I'll do that for you.
Okay.
Yeah. Oops. Oh shoot, Dr. Roman, I just muted you. Hit the wrong button. You need to.
How about now?
Sorry about. Yeah, you're good. Okay. Sorry about that.
I knew you
there we
didn't
go. There
like
we
the lecture, but you didn't have to mute me.
That was my fault. All right. So, guess Dr. Saad, if you have a question to start off, or anybody, you can.
I think I'll see Dr. Kruger. Do you have any questions? I think I saw some comments from Dr. Kruger there, so I'm not sure if she has any questions.
Looks like she has it in the chat, but let's go. Dr.
Okay.
Furman, you have your hand raised. You want to go ahead?
Yeah, so so sorry, Jesse, it's great to see you. Thank you so much for the presentation. And as a geriatrician, I loved hearing about the aging lung. But I was just saying, what's the solution, right? What can we do? In my sense, maybe exercise. When we really, really focus on exercise as a way to kind of have that reserve. So when you do have this aging lung, you can still function and still, go with your grandkids and go to the weddings because you're in shape. But I don't know, do you have any other big solutions, or
Well,
is there a pill? Is there a pill?
All the complex problems we all answer in the same way, and because we have the tools to do it. We exercise, we do immunizations, we eat a healthy diet, and all that kind of thing. The problem is that those are very difficult, not impossible to manage in the laboratory and to show their impact at long age. And what people want, as you know, unfortunately, is they want to be able to take a pill or inject themselves every year with something that takes care of the problem. That's the challenge that we have. is that it's more difficult to create an agent than to make people behave appropriately. So again, I think these senolytic agents are already out there. They're safe for human use. People are testing them in a number of disorders. I think the management of these transporters is going to be important. I think there are people already taking care of many of these issues. I think what's going to be very interesting is that there's a lot of biomarkers that are being detected early on. So instead of waiting until I'm old, Jesse Roman, is testing me at age 30 or 25 with a biomarker and saying, your biomarker is highly positive. You have an aging lung. You're already as susceptible as your grandfather to acute lung injury. You are the one where we're going to spend the resources of this limited healthcare system in trying to limit your problem. So if we can narrow the people that we need to pursue, because we don't have infinite resources, that would be a good way to do so. I see something here from Dr. Emmons about, could our immune system be the problem? Absolutely. Immune surveillance, cancer regulation, regeneration through myeloid cells that go into your organs and regenerate into something else. I think there's a lot of interest on that. As you saw in the hallmarks of aging, the immune system is an important component of we're thinking, but the aging research does not consider that the only thing. There's 10 or 11 aspects of aging that people are tackling, and you can think about how they interact with each other. No, so having an abnormal matrix with an abnormal immune system, with senescent cells, not even able to degrade proteins, and so on and so forth, is just a strategy for death. And then the question is, why doesn't Jesse Roman die? Why does he reach 65 years of age and he's still going on? So we need to start thinking about what are the counter factors that maintain us through all of this.
No.
Oh my God, I see Dr. Eleanor Lederer, another ex-Louisvillian.
Hey, Dr. Roman, Dr. Kruger has her hand up. I know she had it in the chat, but if you want to go ahead and go ahead.
Yeah. Jason, can you help me? Because I don't see everybody on my screen, so go ahead. Chris,
Can
hello.
you hear me?
Yes.
Hi, Jesse. So good to see and hear you. Of course, I'm going to ask a question about vitamin D because throughout COVID, we, read that literature and saw that the original association with lung injury was actually about a decade earlier, that they looked at vitamin D and how it upregulated proteins that improved the mast cells and other cells in the lungs. So I'm just curious. Also, then all the other vitamin D literature, some of it wasn't good, but some of it actually showed giving IV cholecalciferol during COVID reduced your need for ICU and reduced your need for needing to be intubated. I always wondered whether if we had those levels high for those people, they wouldn't have gone on to end up with lung fibrosis. So my big question is regarding the matrix and vitamin D, and is that one of the small additional helpful things that could help prevent this process?
Yeah, Dr. Kruger is correct. And in fact, there's quite a bit of basic science data supporting that idea. In fact, vitamin D, there are vitamin D receptors in lung cells, and vitamin D tackles certain signaling pathways that affect matrix gene expression. It's affected by TGF-beta. So there's a lot of data, to the point that about over a decade ago, people started looking at cocktails that included vitamin D in the ICU, as she just mentioned. I think the problem we're seeing is that many of these studies have been repeated with larger populations, which create more heterogeneity. We're not being able to see the same beneficial effects. So I think in the process of sepsis, for example, acute lung injury, as we add more populations, which creates more problems for us because now we have heterogeneity, we're not seeing the same effects. And I worry about vitamin D because it continues to be an agent that we think it's important for so many things, and yet we're struggling to prove it at the animal and human level to be able to put in the water, just like we do iodine, no? So vitamin D continues to be of very much interest to a lot of people, but we'll wait for more data.
All right, we have a question. Oh, sorry, Dr. Kruger. We have a question from Kimiko Kasama. She's over in the clinical trials unit, one of our researchers. Go ahead with your question.
Hi, wonderful presentation, Dr. Roman. I was curious, given the research coming about with microplastics, especially how those particles are now found in air, water, and speaking to the environmental exposures, what implications does that have for research and the aging lung?
Boy, it has to remember the lung is one of the organs, other than your skin, is the second highest exposure to the environment. And the liters of air that you bring in and out every minute is just incredible. So particles, whatever kind of particles that we're inhaling or ingesting, are going to be an issue. There's a lot of data to suggest that they do activate a number of cells. Nanotechnology are all the way into this. But the question is, how can we use some of these nanoparticles, if not plastics and so forth, which may be problematic, but to get to smaller spaces? No? How do we use this technology to get to smaller spaces to tackle diffuse cells that are deranged and not the entire organ, which relates to safety of interventions? But I think all of these issues first are the safety component of it is a problem. And I consider them as related to inhaled toxins. And it may be inhaled toxins not in the way that we think of it as killing you that day, but years of exposure of them can create a problem and remodel your lung.
All right, we have a question in the chat. Is from a Dr. Hassam Sarakbi. He is actually our new chief of rheumatology. He just started here a few months ago and is a great guy and great, gonna do wonderful things with that program. He wants to know, would aging lung react worse with connective tissue disease?
I'm a firm believer of that, Dr. Harakbi. So I'm an interstitial lung disease guy. We run a clinic together with the rheumatologist because the second, if not the first, largest number of patients that we see with fibrotic lung disease are people who have systemic connective tissue disorders. And there's a lot of data linking the profibrotic process and disrepair to the abnormalities created through all these antibodies and all these rearrangements that you see in connective tissue disorders. Absolutely. I do think a patient with connective tissue disease already has an aging lung. And for people who've done bronchoalveolar lavage in those patients, they have found increases in fibronectin, increases in MMP9, and so forth. That lung is active and remodeling, which may explain why patients who are treated appropriately for their connective tissue disease may show a dissociation where their joints and other problems are controlled, but their fibrotic change continues to evolve, and we need to tackle them in a different way.
Thank you. Excellent lecture. Thank you.
All right, excellent. We have a couple of questions. Dr. Lederer posted a couple of questions in the chat. Actually, I think she may have done it directly, but I'll read them. Her two questions are, does oxidative stress in one organ lead to oxidative stress in other organs? And also, why have antioxidants not been more effective in experimental animals?
So two important points. Number one is if you think about the redox state, the redox state might be a more generalized biomarker of your redox state because the plasma goes all around your body and perfuses all organs. But every organ has its own slate of antioxidants and oxidants and their machinery. So I do not believe that every organ behaves in the same way, although general concept is valuable, but I'm not sure. And again, why do you see a case of sepsis and they may go to acute lung injury and yet they may not develop kidney injury until later on and so forth? So I think, Eleanor, there are distinctive differences between the organs. Number two, every time I talk about antioxidants and fibrosis, people say, well, there's a study 20 years ago that indicated that antioxidants, N-acetylcysteine, did not work. We're looking at this process of oxidation and reduction in a very simplistic way. These agents that we take are taken by mouth or IV, they're degraded. They may not address the kinetics that you're trying to affect. I just think that the idea that we can use an antioxidant that will work is too simplistic. We need to think about this in a more sophisticated fashion. The agents we're using are too simplistic and will not work.
All right.
Thank you, Eleanor.
Yeah. Okay, so that was all from the chat for the moment. Is there any we have time if anybody has any more questions. Dr. Saad, anything you'd like to ask or?
Yeah, just one thing, Jesse. So if we have like, two aging patients like 60s or 70s, and they are exposed to insult, do we know which one will probably get the pulmonary fibrosis versus the other, or both of them are gonna get pulmonary fibrosis, or maybe it's genetic
No, the
predisposition there?
as you know, out of 100 smokers, only 25% of them will get lung disease. So clearly there's an aspect of the host, the genetics of the host, that sort of doesn't respond to an injury the same way. And for the same reason, two aging individuals that by all markers suggest they're the same may behave differently to an insult. We're not smart enough to identify that. But I think you raise a good point. If we were able to identify those individuals, again, we could focus on preventing disease in those individuals rather than everybody else who may or may not need us. But we do not have that available yet, Saad. So we're just not smart enough.
Maybe in the future. So that's something that people will certainly look at.
Yeah.
Fantastic talk, Dr. Roman. It was nice to see you. Nice to listen to you again. It's great to hear from you. So thank you again for taking time, and good luck, and hope to see you soon.
Thank you so much. I am, I don't know the emotions I get when I see all these familiar faces. This is wonderful. I promise that I'll go over there just to drink some coffee with the gang. Thank you all for attending. I know you're busy at your schedule. Jason, take me away. And Mohammed, thank you for the invitation.
Before we go, as you know, and you should know because you're the one that started this, we have a tradition with the UofL Department of Medicine with Grand Rounds that our guest speakers get a Louisville Slugger bat. So I know you already have one, but you're going to get another one.
No, but this is a good one because it's a return to the future. This is wonderful. I think, friends, I would urge you all, those who have not been here as long as I have, we got to innovate and we got to move, but it's the traditions that sustain the mission of what academic medicine is about.